All right, well, good afternoon. I'm Dr. Angela Herbie, and on behalf of Creative Educational Concepts, I'd like to welcome you to today's educational activity, the Metrics, Decoding the Real-World Impact of Therapeutic Advances in Neurofibromatosis Type 1 Associated Plexiform Neurofibroma, Management across Pediatric and Adult Populations. Today's program is supported by an independent educational grant from SpringWorks Therapeutics. Today's program is brought to you by Creative Educational Concepts, an award-winning accredited provider of continuing education for clinicians worldwide. Today's activity will include some discussions of products or devices that are not currently labeled for use by the FDA, and we will be sure to point these out in our discussions. So again, my name is Angela Herbie, and I'm an associate professor of medicine and pediatrics, and I direct our adult neurofibromatosis clinical program at Washington University in St. Louis, and I also run a basic translational research lab. And I'm joined today by Dr. Miriam Bornhorst.
Hi, I'm Dr. Bornhorst. I'm a pediatric neuro-oncologist at Anna Robert Lurie Children's Hospital in Chicago. I also take care of patients with neurofibromatosis type 1, so I'm the co-director of our program there, primarily taking care of patients who have tumors.
Hi, my name is Carlos Romo. I'm an adult neuro-oncologist at Johns Hopkins here in Baltimore, and I also am an assistant professor there in the NF Center and take care of mainly adults with the different kinds of NF.
All right, and here are all of our disclosures. Again, I'm not going to read through everything, but you can see them listed here. So I'll start off just by going through our learning objectives. So first, to assess the neuro-oncologic features of neurofibromatosis type 1, including tumor types, neurologic signs, and to support early recognition and inform clinical decision-making. 2, we'll evaluate the use of MEK inhibitors in the management of neurofibromatosis type 1 associated plexiform neurofibromas in both pediatric and adult patients, including team-based care in order to manage adverse events. And 3rd, to develop evidence-based interprofessional care plans for pediatric and adult patients with neurofibromatosis type 1 that reflect current clinical standards and support individualized longitudinal management. So I'll start off just by going through some of the clinical features and diagnostic criteria. So this figure shows the neurofibromatosis, and what we're focusing on today is neurofibromatosis type 1, which is the most common tumor predisposition syndrome. It affects about 1 in 2,800 people worldwide. And people with NF1 have various manifestations that occur throughout the body. So there can be central nervous system manifestations such as gliomas, learning disabilities, ADHD, autism. There are obviously the skin manifestations such as the cafe au lait macules and skin fold freckling. Different skeletal manifestations, including different, things like dysplasia of the long bones, as well as increased risk of osteoporosis. The peripheral nervous system manifestations, the biggest one we'll be talking about today, are plexiform neurofibromas. And then also there can be manifestations affecting the endocrine system, the GI system, as well as cardiovasculature. So I think one very important point is that the timing of these different manifestations is, different throughout a patient's trajectory in life. So around the time of, birth or infancy is when we tend to see the cafe au lait macules. We can see things like the orbital dysplasia, tibial dysplasia, and plexiform neurofibromas we think are present at birth but may not manifest themselves until infancy or early childhood. And then it's really early childhood and adolescence where we start to see things like the learning deficits, ADHD, autism spectrum disorder, motor and speech delays, optic pathway gliomas. And then adolescence to adulthood are where we start to see and pick up on things like the Lisch nodules, the scoliosis, the different neurofibromas. And then it's really in adulthood that we worry about sort of the high-grade malignancies such as malignant peripheral nerve sheath tumors, which are the aggressive sarcoma that can arise from transformation of benign plexiform neurofibromas, as well as other cancers such as breast cancers and high-grade gliomas. So just a couple images to kind of show you what some of these different manifestations look like. So cafe au lait macules you can see on this slide, and these are often the first sign of NF1. They are often present at birth, and they can continue to develop and darken over time. So by 1 year of age, about 80% of patients will have greater than 6 of these cafe au lait macules. They're certainly not a marker of severity, and they're present in the vast majority of patients with NF1. On the other side of the slide, you can see a couple examples of skin fold freckling. So this is freckling in areas that don't typically see the sunlight. This is also fairly common clinical sign. So they're present in about 75% of patients, and again, usually detected in childhood, so around 5 to 8 years of age. You can see an example of Lish nodules here. They don't have any effect on vision. You can see them when the iris is a light color, like in this picture, but you can imagine somebody with, brown pigmented eyes, you're not going to be able to see these without a slit lamp examination. And then you can also have choroidal abnormalities. These are present in just over half of patients. Again, these are asymptomatic, and identification would, require a thorough ophthalmology exam. This slide can show you some images of some dermal neurofibromas, as well as the bone abnormalities that we can see in patients with NF1, like the long bone dysplasias and the sphenoid wing abnormalities. And then below those x-rays, you can see an MRI image of a very large plexiform neurofibroma that has this sort of bag of worms appearance on MRI. And then on the other side of the slide, you can see an example of an optic pathway glioma. So this slide is just showing you the diagnostic criteria, which were established in 1988, and for the most part have stayed the same. They were updated in 2021 with a few notable changes. So patients have to have 2 or more of these criteria to have a diagnosis of NF1. So 6 or more cafe au lait macules, and the size depends on where a patient is in terms of puberty. Freckling in the axilla or groin, 2 or more neurofibromas of any type, or 1 plexiform neurofibroma, an optic pathway glioma, 2 or more Lish nodules, or 2 or more choroid abnormalities. This was one of the changes added. A distinctive osseous lesion, such as sphenoid dysplasia, or tibial bowing, or pseudarthroses of a long bone, or a heterozygous pathogenic NF1 variant with a variant allele frequency of 50% in apparently normal tissue. This genetic testing was what was added to the newest criteria. And then finally, if a parent meets the diagnostic criteria, then you just have to have 1 other of those that I just listed above. So I want to point out, as I said earlier, patients with NF1 can have manifestations in many, many different organ systems. And so, because of that, the patient is going to need multiple medical specialties involved in their care. And so this Venn diagram sort of shows the patient and the caregiver kind of in the center. And I would say there should also be sort of a NF1 champion there, whether that be, somebody in oncology, genetics, or neurology, but someone that is going to help make sure that the patient has all the other specialties that they need involved. And I've listed some of them in the sides here, and you can see, radiology, genetics, dermatology, ophthalmology, various surgical specialties, nutrition, social work, psychological therapy. All of these are important to the care of an NF1 patient. So again, when we think about this as a neurology meeting here, so the role of the neurologist, is I think to contribute to diagnosis and initial evaluation of both central and peripheral manifestations. So these can be things like the neurocognitive impairments, weakness, signs of tumor growth, optic pathway gliomas, seizure disorders, and cerebrovascular abnormalities. And really monitor those ongoing neurologic symptoms like pain, weakness, numbness, and then helping to manage complications such as seizures, headaches, and neuropathy. And, obviously some of the testing in terms of peripheral nerve ultrasound, EEG, and other things of that nature. So Irene Moss is a patient advocate and caregiver. She lives in Alabama with her husband of 24 years. They have 2 children, Philip Jr. and Helen. And again, they have NF1. And Ms. Moss is an avid advocate for the neurofibromatosis patient and research communities.
The challenges of accessing a neurofibromatosis clinic, or a clinic that is well-versed and experienced in neurofibromatosis care, access to specialists that may be needed in that continuum of care, is very, very hard in our country, in the United States specifically. We were very fortunate when we received our diagnosis. 5 minutes away was one of the best NF clinics in the country. So it was not our experience, but in my 10, 11 years of managing this with my family and engaging with parents and patients in the NF community, our experience is very unique. Most families do have to travel at least some distance, sometimes a long distance, to access the care they need. That can affect your job, that can affect your employment, that can affect your school, that can affect your pocketbook, your finances. And we're also a middle income family with insurance. Not everybody has that ability. So if you need an MRI and you're 4 hours away, having the ability to do that, but then having to go back to get the results of that, or having to come do blood work or a scoliosis scan or a DEXA scan, if those appointments can't be coordinated, that's a very expensive both time and financial commitment for that patient or that family to be able to travel back and forth and do that. And with NF1, because there are so many learning disabilities and sometimes multi-generational diagnoses, the ability to maintain successful employment is sometimes a challenge. So you add the distance and the financial toll it takes on a family to be able to access that care, along with the ability to maintain employment, to be able to do that. It is a huge, huge stressor and frustration.
So we'll hear from some patient advocate views throughout the talk that we give today. And we also kind of intertwine some cases in there just to bring up some discussion points. And we'll have some polling questions throughout as well, just to get people to start thinking. So Angela T. is a 7-year-old female who's experienced some mild learning difficulties and clumsiness in school, which has been attributed to behavioral issues and not formally evaluated. She has a younger brother, 4 years of age, and a sister, 2 years of age. So at her annual physical exam, her pediatrician notes axillary freckling and small soft cutaneous nodules. Ophthalmologic exam finds Lisch nodules, and so NF1 is diagnosed based on the clinical criteria. The parents don't have any clinical characteristics of NF1. So again, on exam, we see 9 cafe au lait macules greater than 0.5 centimeter, bilateral axillary freckling, mild hypotonia and coordination difficulty noted, no scoliosis, no long bone abnormalities, visual, spatial, and processing deficits, and attention and executive function concerns. So what do you recommend for this patient? And this is not an exhaustive list, but things to think about, and kind of, again, pointing out all of the different specialties that might be involved in care of this patient. So continual typical pediatric care, genetic evaluation. We have some neuropsych manifestations, so formal neuropsychological testing. There's clumsiness noted, so of course perhaps occupational therapy would be helpful. Referral to ophthalmology. It's important to have a good eye exam and look for any visual deficits that may occur. Speech language pathology testing, MRI kind of based on symptoms. Certainly it sounded like she was having some issues, so school support would be an important thing to look into, things like an IEP. And then some baseline imaging, and really, I think key, referral to a comprehensive NF1 clinic. So again, some of the recommendations that were made, we kind of talked about these things on the last slide. Potentially genetic testing, you don't need it for a diagnosis. Some patients and families want to know these. Like, as I mentioned, the comprehensive ophthalmologic exam, we're going to get baseline neuroevaluations and really monitor things developmentally very carefully. Refer to developmental behavioral pediatrics so that you can have adequate care for ADHD and any kind of behavioral support. Genetic counseling is really important to discuss inheritance, family testing, reproductive planning as a patient gets older, occupational therapy and speech therapy. I think, making sure that parents are plugged into supportive networks like Children's Tumor Foundation or some of the local NF support networks. And then, importantly, annual follow-up for NF1 surveillance. I think these are some of, the common missed opportunities that are sometimes seen in the community, which our patient advocate kind of brought up. But, failure to recognize diagnostic criteria for NF1 is certainly a problem. Or underestimating the impact of mild developmental delays that they can have as a patient progresses. Delayed referral to specialists. Failure to take an adequate family history could lead to some missed opportunities for diagnosis. And certainly, not coordinating with schools and overlooking emotional and behavioral health can negatively impact a child's trajectory. And then not referring to an NF1 specialty clinic, means that you're not getting kind of that integrated care that I think is very helpful for this patient population. So Rini Moss is going to, again, talk to us about some of the difficulties in diagnosis.
For us, ours was rather unique. But as I've over the years found out, it's not that unique. Our son was not diagnosed until he was 6 because he does not have the usual capiole spots. He doesn't have freckling in the groin or armpits. He does not have Lish nodules that would have been picked up in an eye appointment. He does not have learning disabilities. Some of the things that would be kind of the main dominant issues that would arrive with NF diagnosis. His diagnosis came because he had a tumor in his neck that we thought was a lymph node, which fast forward a year is how long it took for them to realize it wasn't a lymph node and it was in fact a plexiform tumor. Then a year later, our daughter was diagnosed through genetic cascade testing, and with an autosomal dominant genetic condition, that meant mom or dad had to have it. And so at age 36, my husband was diagnosed with NF1. So we have 3 different presentations or phenotypes of NF1, same genetic variant.
So at this point, I'm going to turn things over to Dr. Bornhurst to discuss MEK inhibitors for the treatment of symptomatic inoperable plexiform neurofibromas in the pediatric population.
Great, thank you. So I'm going to start off by just giving an overview of the different tumors associated with NF1, and then the talk today is really going to focus on plexiform neurofibromas. So NF1 is associated with a number of different tumors, and you can see the list here. And if you look at the pathway on the side there, part of the reason that patients with NF1, or the biggest reason that patients with NF1 are predisposed to tumors is because when you have NF1, you have a alteration in a gene called the NF1 gene, and that is a really important gene for regulating your RAS-MAP kinase pathway. And so if you don't have that neurofibromin there to serve as a stop mechanism, so basically when a signal hits the cell and that signal is not supposed to get to the nucleus to cause that cell to divide, neurofibromin is supposed to be there to stop that signal. But if neurofibroma is not present, or if it's not working properly, that signal can slip through and then that cell can divide, and then you can get more and more and more cells, and that's how you ultimately end up with a tumor. And so all of these tumors that are shown here are known to be basically caused by this sort of loss of heterozygosity type of event where you lose your neurofibromin function and then the cells are dividing more than they should be. And so plexiform neurofibroma is a tumor that develops in about 50% of our patients with NF1. These are usually congenital, which means that it's something that's present, even really early after birth. And we can generally see them by 1 to 2 years of age, but then they will grow over time. And so families will always say, well, if I don't see anything at 2 years of age, that's a good thing. And the answer is not necessarily. It just might be that we're not seeing it yet because it's too small, and it will continue to grow over time. They do most rapidly grow in children less than 5 years of age, but we can see periods of rapid growth after that, particularly kind of in our I would say, teen years. And we know that these tumors now are not just tumor cells, but they're sort of a matrix of a lot of different cells. So they have tumor cells, but they also have fibroblasts, endothelial cells, mast cells, so they have immune cells in there as well. And so they're not just one component. They have a lot of different cellular components that makes them a little bit harder for us to treat because of that. They do tend to be highly infiltrative, so you can see sometimes tumors that are very like focal or localized, but generally they'll sort of creep into everything. So if you've ever seen a picture of a patient, or if you've ever taken care of a patient with plexiform neurofibroma, you oftentimes will see the tumor kind of creeping into the muscle, creeping around the nerves, which obviously makes them very difficult to remove surgically, and also very difficult for us to manage as well. Because of the fact that they will kind of creep into different places, they can oftentimes cause some symptoms. And the most life-threatening symptoms that we can see would be airway dysfunction, visual impairment, bowel bladder dysfunction. We can also see motor dysfunction as well. And then there's the pain and the disfigurement that can come with these. Most patients have more than one PN-associated morbidity. So if you have a plexiform neurofibroma and it's associated with symptoms, usually you have more than one. So you can see pain and motor dysfunction, for example, or pain and disfigurement. I think it's also important to mention that the symptomatic plexiform neurofibromas tend to be larger than your asymptomatic ones. You know, when you have a patient who's complaining of a tender symptomatic plexiform and you're really only seeing a small part of it, that would be a good time to get an MRI, because it's probably deeper than what can be appreciated on your exam. Most plexiform neurofibromas are benign, but it's important for me to mention that about 8 to 13% have this potential risk for developing it into an MPNST, and that risk is definitely higher in patients with NF1 and higher in patients that have extremely high tumor burden. So how do you manage plexiform neurofibromas? I think the first question that we always have to ask ourselves is this a tumor that can be observed, where we just look at it, watch it over time because it's not causing any problems or issues, or is it something that needs to be treated? And the decision on whether you can observe or to treat oftentimes is dependent on the age of the patient, the growth status of the plexiform neurofibroma, the growth rate, impending morbidity. So if you have a tumor that's about ready to impinge on the cervical cord or something like that, you know, that's something that you probably want to treat more so than something that's just sitting there and growing outward and not necessarily causing any problems for the patients. And then, of course, the progressive nature of the tumor. If it's something where you're getting MRIs every 6 months and every single MRI you're seeing growth, that's something that you're probably more likely going to treat than one where you see a little bit of growth and then nothing for multiple MRIs in a row. It does look or kind of break down your observation versus treatment here. Of course, for the observation, again, not everybody who has a plexiform neurofibroma will require treatment. In fact, a majority of patients with plexiform neurofibromas do not require treatment. But if you are going to do treatment, the goal should be to improve or prevent associated morbidity. And then you should also consider sort of what the evidence shows. So, you know, again, is this something that is going to cause problems or not? Once you decide to do treatment, there are two different types of treatments now that we consider to be the most common, or I guess you could say standard of care, and that would be surgery versus medical treatment. Before you go to treatment, you should, of course, rule out a malignant transformation. If there's an MPNST there, it's going to be treated very differently than if it's a plexiform neurofibroma, and that can be determined based on the rate of tumor growth, association with pain. Oftentimes your MPNSTs are firmer to touch than the plexiform neurofibromas. You'll see them growing faster. If there is a clinical concern for anything other than a plexiform neurofibroma, you should consider a biopsy. And if it's easily removable, I've had some patients where I'm concerned and I just say, go take it out. It's easier for us to do that than to even try to think of any other types of treatments. Once you've ruled out the fact that this is a MPNST and it's a plexiform that you still want to treat, then you should think about, is surgery better for the patient or medical treatment? And sometimes even is a combination of these two best for the treatment. For surgery, the patients where we can get a complete resection fairly easily without any morbidity, that's probably the better answer. You take it out, no morbidity associated with it. You don't have to really think about long-term following and long-term management of that. that. But for the patients who have, large plexiform neurofibromas that we know that we can't take the whole thing out, or even, if you were to do surgery, that surgery would be associated with morbidity, then medical treatment might be the best way to start. So this is our patient that we had talked about at the beginning, Angela. So now at 10 years of age, she develops a slowly enlarging diffuse swelling along the left lower jaw and neck. It feels rubbery and is sometimes tender, grows slowly or steadily but unpredictably. It's non-resectable due to its size and location and causes cosmetic deformity and periodic discomfort. And the MRI confirms a plexiform neurofibroma in that location. Over the several years, the lesion causes noticeable facial asymmetry and mild difficulty with chewing and speech. So there's your morbidity associated with it. She begins to experience neuropathic pain and occasional airway discomfort by age 13 to 14, and function and quality of life decline, and the mass becomes increasingly prominent. So at 15 years of age now, so 5 years after we started noticing this tumor for her, she's having progressive pain, impaired function, and disfigurement that are negatively impacting her quality of life. So what would you recommend for this patient? So I think for all of you who have the iPads up, the question should be coming up. And the answers would be continued observation, multidisciplinary tumor board, surgery, radiation therapy, or systemic therapy. Great. So multidisciplinary tumor board is definitely our winner here. Continued observation, systemic therapy is the other one that got some votes. So very, very good. So this was really trying to talk a little bit more about the multidisciplinary team management approach, but I think starting systemic therapy is also a very appropriate answer for that question. This is just showing an algorithm for the multidisciplinary team, and I think for anybody who takes care of patients with NF1, you know that it's not something that you can oftentimes do on your own. You need to really have other people sort of contributing to your care. So this talks a little bit about if you have a plexiform and it's asymptomatic, you can observe, but if it's symptomatic, you have to think again about organ compromise, progression, disfigurement, and pain. Once you've decided you're going to treat, then you have to think about what type of tumor do you have, who are the best people to get involved. So for example, if you have something that's involving the neck, perhaps you need to have ENT involved to make sure that it's not causing any airway issues or something that they would need to help with. And then again, going to is it surgically resectable or not? If it is, you could consider surgery, and if it's not, then you'd want to consider starting your targeted therapy. So our patient had a tumor that was not able to be removed through complete resection, and the morbidity associated with that resection would have been too much for her. So in consultation with her family, it was decided that she should receive systemic therapy. So now we'll start talk a little bit about what are some of the systemic therapies that are available for patients with NF1-associated plexiform neurofibromas. There are 3 primary types of therapy that we generally think of as being successful for patients who have these types of tumors. And again, if you look at this RAS-MAP kinase pathway picture, you can see at the top there, right at the cell surface, there's a receptor tyrosine kinase, and that's where the cell hits, or the signal hits the cell to kind of go through that pathway to get to the nucleus. And so cabozantinib is a receptor tyrosine kinase inhibitor. So when the signal hits the cell, this drug actually blocks that signal from getting into the cell completely. And so that is one therapy that's been used to sort of block that activation of the pathway, and it does help treat the plexiform neurofibromas. And then further down that pathway, you'll see RAF, and then you see MEK. So the MEK inhibitors inhibit that MEK protein, and selumetinib and mirdametinib are the 2 that we'll focus primarily on today, but there are also other MEK inhibitors, binimetinib, trametinib, cobimetinib is also another one that's not listed on here. So there are other MEK inhibitors also that act very similarly by blocking that protein. So when we did the clinical trials looking at these drugs, the outcomes looked at not only the plexiform neurofibroma growth and response to the treatment, but also looked at patient-reported outcomes. So we are finding now that it's not just how well can we treat the tumor, but does the treatment actually improve patient quality of life. And so selumetinib and mirdametinib are 2 MEK inhibitors that are now FDA approved because of the results from the clinical trials. And like I said, cabozantinib is also being used for some patients. So this is an overview of the partial response rates for patients who've been treated with MEK inhibitors and cabozantinib. And you can kind of see here selumetinib and mirdametinib both had pretty good partial response rates. And cabozantinib, which is on the furthest side, had probably a lower response, but also, I mean, close to 50% of patients did respond to that drug as well. And really for NF1-associated plexiforms, this was exciting data for us to see because it was the best responses we'd seen for any of our therapies. So cabozantinib and the MEK inhibitors were our first drugs that we had tried that really gave us a nice response that you're seeing here. So the SPRINT trial is a trial that helped lead to the selumetinib approval through the FDA. This was a phase 1-2 trial. So this is the data from the phase 2 part of it. Again, this was only for children. So I'm a pediatrician, so my stuff is most going to be pediatrics, but Dr. Romo will talk a little bit more about the adults trials. And with this, the patients had to have NF1 and a symptomatic inoperable plexiform neurofibroma. And you can see baseline demographics here. And then you can also see primary endpoint and secondary endpoints. And again, the primary endpoint really was how well does that tumor shrink when you're giving the therapy, but the secondary endpoints also looked at duration of response, safety, and those reported outcomes. So how well did patients respond to the therapy in terms of their quality of life? And so this table right here is looking at the data from the SPRINT trial compared to your natural history. So what they did is they took patients who were treated with the selumetinib, and they compared those patients in terms of the progression of the tumor to patients who were on a natural history study through the NIH. And what they found, as would be expected, is that patients who were not on treatment had a pretty significant progression or fairly low progression-free survival rate. So most of those patients would progress, while on the selumetinib therapy, the progression-free survival was definitely improved. So fewer patients progressed while they were on treatment. And you can see on there sort of the median progression-free survival for these patients that were on treatment. So this drug is not without adverse events. So I think that it's important. We talk about the benefits of MEK inhibitors, and I certainly talk to my families about how great these are going to, potentially work, and how, this is something that's definitely an option for them. But it's also important to talk about the adverse events that have come with these, because some of them are pretty significant. So you can see vomiting in some of the patients, abdominal pain, diarrhea, nausea, mouth sores is something that we see, acneiform rash. Basically, any teenager you put on this drug is going to get acne. So that's a very important thing to say. If you've got a kid who's never had acne in their life, you need to say to them, this is going to happen. Let's figure out how to treat it before we even put you on the drug. You can also see increased CPKs, which most often we don't really care about unless it's causing muscle fatigue. So if you get a high CPK and the patient's completely asymptomatic, it's probably not a problem. But if you're having muscle skeletal pain, fatigue, things like that, then you do definitely want to think about changing your dose based off of that. And then you can see that there's also constipation and a number of other things. And so headaches, hematuria, proteinuria, edema. The edema is actually something that's pretty real. I mean, I had one poor patient whose eyes completely swelled because of the edema in their face. So something that you also want to consider. And paronychia can become bad enough that patients need to have their nails removed. So something else to really think about. The AEs of special interest for selumetinib are listed on here. So I think that something you'll also hear with all the MEK inhibitors is that there is a potential that it can cause some cardiac decrease in the ejection fraction, as well as some potential ocular side effects. And so it'll be very important when you place patients on MEK inhibitors to follow them closely for these. Blurred vision is probably the main ocular side effect that we see, but you can see that there are some others listed on there that could potentially be significant. And then again, with the ejection fraction, when it decreases, usually it comes back up, or again, when you stop the drug, or sometimes it even comes up and down and on its own, but definitely something you want to keep in mind. Hypertension and some bradycardia and tachycardia were also seen. So there are some warnings and precautions based off of some of these side effects. You can see them on here. Again, anytime you put somebody on a MEK inhibitor, you have to think about ocular toxicity as well as the cardiac toxicity. So eye exams and echoes are very important for all patients. Skin toxicity is very real. I would say if you have an oncoderm provider, I would definitely get them involved fairly early on in treatment, because the skin rashes can become quite significant, quite severe. And if you can get them under control, you can keep the patient on treatment, but it's really a matter of identifying the best therapies. GI toxicity, you can also see increased risk of bleeding, particularly since vitamin E is known to inhibit platelet aggregation. So where I see this mostly would be the females who are on treatment. They will have oftentimes worse menstrual cycles when they're on therapy. And then, of course, there's that embryo-fetal toxicity. We don't know what a MEK inhibitor would do to a developing fetus, so it's very, very important for patients not to become pregnant while they're on treatment. And then this is the patient-reported pain outcomes. And so I love this slide because I can tell you that, again, this was the first study that I did for patients with neurofibromas where they actually started reporting improved pain. And that was really, really exciting for us. So you can see on here that there was definitely some improvement in the pain intensity over patients or over time. The ReNeu trial is the trial that was done for mirdametinib. So this led to the FDA approval of mirdametinib in children and adults with inoperable plexiforms, and I'll focus mostly on the pediatric or the child part of that. So this again is sort of our cohort. The dose that was used, the primary endpoints are the same. So looking at tumor response as well as quality of life. And this is showing a waterfall plot. And so you can see on here, so anything that's up is bad because that means it progressed. Anything is down is good because that means that it shrunk. And you can see that a majority of the patients had at least a little bit of shrinkage of their tumor, and some of them had actually pretty significant shrinkage of their tumor. So I think down to about 80% at the far side there. You can also see with this ReNeu study, very similar to the other study that was done for selumetinib, that the patient-reported pain scores improved overall, and patient-reported quality of life was also overall improved. And so really patients feel better on the MEK inhibitors in general. This is the adverse events for the ReNeu study, and I'm not going to go over everything again because they're essentially the exact same thing. So there's really, I mean, people ask me this all the time, is there a difference between the one drug and the other drug? And if you look at all the side effects, and you can maybe pick out little teeny differences here and there, but honestly, they're essentially the same. So you're going to see almost everything on one list as you're going to see on the other list. And then the warnings and precautions are the exact same as what they were for the other MEK inhibitor, where you have to think about ocular toxicity, cardiac toxicity, the dermatologic toxicity, and then, of course, that embryo-fetal toxicity or the potential risk for that. So I'm going to pass it back over to Angie now.
Momentarily, yeah.
Yes.
So we'll kind of go back to this patient that we've been talking about. So Angela's now 19 years old, has been receiving selumetinib continuously for symptomatic plexiform neurofibroma. The tumor shrank and it's now stable, and her pain is also improved. However, your indication for selumetinib is for pediatric patients 1 year of age and older. So at this point, what would you do? Stop therapy because she's stable, switch to mirdametinib, or stay on selumetinib? So stop therapy. No one said that. Switch to mirda. Nobody said that. Stay on selumetinib was what everybody had answered. So I think stopping therapy is not something that I would do. I think especially in the, for sure kids and teenagers, I think there's still a pretty significant chance for kind of rebound, pain, and tumor growth if you stop a MEK inhibitor when they've been on it. When mirdametinib got FDA approval, if I had somebody that I had inherited from pediatrics who was on selumetinib, I didn't switch them to mirdametinib. Certainly from that point forward, mirdametinib is the drug that currently is FDA approved for adults. And so any new patients that I was starting on a MEK inhibitor, it would, be mirdametinib. we would have a conversation still with the patients about the data for selumetinib and the data for mirdametinib, with kind of the big difference being how the medications are dosed. Dr. Romo is going to go over that a little bit later, though. So, we thought this patient was a good one to kind of bring up this idea of transition of care from the pediatric to the, adult setting. So I'm going to hand over.
Thank you.
Yeah.
And we have some good questions already from the audience, but maybe we'll wait until the end to answer them. But let's talk a little bit about the transition of care, and I will discuss this mainly from a perspective of how do you start thinking about this more so than what do you actually do now that you're an adult and what do you monitor at that point. But certainly if anyone in the audience has questions about more specific details of how do we actually monitor patients in the adult NF Center, I'm happy to answer those questions. So first we'll again hear from our caregiver and patient advocate.
So of all the questions I have to think about as a parent of children with NF, the transition of care to adulthood is probably the one that I am most passionate about and most ill-informed about because I'm in the midst of it myself right now. And what I would say to care teams or nurses or that may be hearing my voice right now is do not underestimate the power of peer support and making sure that if you have the ability to connect your patients to those patient communities, it is so critical. It is very difficult to ask really questions that don't have black and white answers related to this because every family is unique. And so hearing from your doctor or your nurse is one thing, but hearing from a peer who's been there ahead of you or is in the midst of it, the combination of those two things are so very important. Especially when you may not have access to an NF clinic. There's a lot of online support systems. There's patient organizations that are very, very good about connecting newly diagnosed or families that are dealing with whatever the circumstance is. So transitioning to adult care, it's hard enough transitioning a child that doesn't have neurofibromatosis to adult care when HIPAA issues happen and power of attorney may be playing into it and all of the different things that happen. So I learned a lot from hearing from other families. So before our son was turning 18, it literally over a year ahead, making sure that we were thinking about what that would look like and explaining to our son that I don't have access to your patient portal anymore unless you give me your login, which is going to be up to you.
So transition to an adult NF center when possible, I think is very important. Unfortunately, I have seen patients in clinic who were told that maybe once you're turning 18 or 21, that you no longer need to monitor things and you'll be fine, which is absolutely inaccurate. Because as Dr. Hervey was saying at the beginning of this talk, there are manifestations of NF1 that actually don't start to occur, or the higher risk is during adulthood, such as the risk of breast cancer or high-grade gliomas or MPNST. So there is absolutely a need for transitioning of care when possible to an adult NF center. Unfortunately, as I'll show you in some of these slides, there is a lack of access to NF care, period, but more so to adult NF centers. There are websites, and I'll show you a couple of them here in a couple of slides, that can help patients find those providers that either see adults or see adults and children. Hopefully you're lucky enough to be in a center where you can get both adult and pediatric care, and sometimes we see patients as families together with parents, affected parent, or children together. But in any case, there's this paper published in 2018 with some recommendations about how to think about transitioning. Of course, during pediatric care, this is a family-centered approach. I would argue that during adulthood, this can still be, and I encourage it to be still a family-centered approach, because a lot of the decisions require the support of the family to keep on with the managements and the monitoring that is necessary. As said before, multidisciplinary care is appropriate for both pediatric and adult patients, no difference there. Length of appointments, really, even though this table here suggests that adult visits are short, I spend no less than an hour with my adult patients, and sometimes even more, especially when there are complicated cases. The adherence of care, again, there's good pediatric patients and parents, and there are good adult patients as well that adhere to the recommendations, and people that need a little bit more help or support following those recommendations. Now, one of the things that we should think about as we're transitioning from pediatric to adults is that it's not an on and off switch that you just turn on. You're 18, now you need to transition. Ideally, there should be a plan for transitioning, and that plan should not start the year you're turning 18. Ideally, you should be thinking about this way in advance. And very importantly, I think, is teaching your child or the pediatric patient to start owning their care and becoming more empowered and independent. And again, this is not something that spontaneously happened when they turn 18. This required effort from both the patient and the parents or whoever's supporting that patient. Now, as I mentioned before, limited staff availability, and not all centers will allow to see pediatric patients beyond the age of 21, sometimes 25. When possible, you should start thinking about these barriers. And if there's a lack of adult providers in your area, is there a possibility of seeing someone on a televisit? Maybe that is the case for you. Thinking about what other centers you could go to and visit. We often see patients from the surrounding states come to Baltimore for their care, and that is perfectly appropriate. However, one of the problems that we frequently encounter is that insurance companies or Medicaid might not allow them to come and visit with us. And so as you're choosing your insurance, try to think of, is my NF center within the network or not? Because that could be a big headache in some cases. Now, also attend meetings to educate yourself. If you're a patient, I would encourage them to go to CTF, the Children's Tumor Foundation's Summit, where you can learn about your care and what is out there happening in terms of research. If you're a provider, thank you for being here and learning more about NF, but also figure out who else could I contact as part of this multidisciplinary care paradigm to help me manage these patients. So there's one of these tools that can help. This is the one here that you can scan this QR code, got transition. There are others, as I said before. One of them is the Children's Tumor Foundation that specializes in NF care, and it's not exclusively for children, but also for adults. There are local NF centers that have case managers or social workers or a nurse practitioner that is the coordinator for the clinic that can also help. And there are also patient-led organizations in different places in the country, not just CTF, but others that are amazing at connecting patients and their families with providers that might help with this transition. So let's talk a little bit about long-term planning, and we'll hear again from our patient advocate.
The long-term care can affect quality of life significantly. Sometimes, having to balance that. If you have multiple family members, having to balance attention with one child versus the other. Our son is the one who's had to deal with acute care, acute treatment, and our daughter is really just one that is dealing with surveillance. So the long-term care for her looks very different than the long-term care for my son. For her, it's mentioning it, making sure she's aware of it. As she moves into puberty, we've been very transparent about family planning. I hope there's a lot of reasons why you wouldn't want to have a baby when you're 17, but there's a lot more on the line. And so we, along with our care team at the NF clinic, have had real conversations with our children about what NF looks like, and reminding them you have 3 people in our family look very, very different. It's not a predictive condition. Just because you had a very mild case does not mean your child one day will not have a mild case.
So these points are, again, talking about things to consider as you're transitioning children to adult care. As I've mentioned before, this is a little bit repetitive, but identification of an adult provider that can help with their care, establishing and monitoring a plan over time, and being able to share medical records, consider insurance problems or considerations that may occur in the future, and thinking about the tools that are available and share those with your patients and family members in order to help with this transition. Now, I'm going to talk about the MEK inhibitors as a treatment option for symptomatic inoperable plexiform neurofibromas, but we're going to switch from adults. And you'll hear a lot of what Dr. Bornhorst already talked about in terms of the studies, the side effects, and the results. But it is an exciting time, and so let's talk about this. Mary G, this is a new patient, a 45-year-old woman with facial plexiform neurofibroma that is also causing significant deformity comes to your clinic. She mentions that her pain has been present for many years, and the semiology of the pain has not changed. The tumor itself does not seem to be different, either in size or consistency. And so you obtain an MRI to make sure that you're not missing anything internally that could be concerning. Fortunately for this patient, the MR does not show any features of concern. So what do you do next? Do you biopsy this tumor just to make sure that this is not a malignant peripheral nerve sheath tumor because it's hurting? Do you start a MEK inhibitor after a multidisciplinary team discussion, or do you refer this patient for surgery? So I think we have consensus on starting a MEK inhibitor after a multidisciplinary discussion. Yeah, and I would add that another option here could have been, if the patient is primarily concerned about her pain, manage the pain without the necessity of starting a MEK inhibitor. And I don't think surgery discussion is inappropriate, so I would still, if the patient was willing to see a surgeon, I don't think that's a bad idea. There might be some debulking surgery that might help her face look a little bit more symmetric if what she's concerned about is mostly the disfigurement component of the plexiform neurofibroma. A biopsy, probably not the best answer here since the pain has been the same. The tumor is not increasing in size. There's no nodular component. We are told that the MRI features beyond just the size are reassuring. So I would probably not automatically refer a patient for a biopsy just because there's a plexiform neurofibroma that's present. Okay, so talking about the RENEW study, as Dr. Bornhorst mentioned, this is a phase 2 open label study that included two groups of patients. One was the pediatric cohort of patients that we've already discussed, and now we'll focus on the adults aged 18 and older. And again, the population in this study were people with NF1 who had an inoperable, progressive, and or symptomatic plexiform neurofibroma, and the intervention was to administer mirdametinib. And it was administered based on body surface area at the dose that you see here, 2 milligrams per meter squared, twice daily, with the maximum dose being 4 milligrams twice daily. And they received this medication for 28-day cycles with 3 weeks on and 1 week off. And they received this treatment for up to 2 years. And the goal was to see if patients on this study had a response measured by the volumetric shrinkage of these tumors on an MRI. So a target neurofibroma was chosen in people who had multiple tumors, and volume was measured over time to see if it shrank or not. The idea was that if you meet this endpoint of 20% reduction, which is just an arbitrary number that was used because of historical references and precedents, then you would be qualified as having an objective response. However, they also evaluated duration of response, the safety, meaning side effects and tolerability, and also, very importantly, the quality of life and physical functioning and pain of people with neurofibromas in the setting of NF1. You can see here that we had 58 adults as part of this cohort, good distribution between male and female patients. The locations of the tumors were in different body parts, and there were a bunch of different reasons why they joined the study, but pain and disfigurement were the main ones. Several of them, 63% of them in kids and 53% in adults, had progressive tumors that had been growing over time as measured by MRI changes. Now, this is the same waterfall graph that Dr. Bornhorst shared with you, where we see, again, everything going up is progressive tumors, everything going down are tumors that are shrinking. You can see, again, that in adult patients, the vast majority of them had some shrinkage of their tumors, several of them meeting that 20% or more. That's the dotted line you see at the bottom here, 20% or more reduction in the volume of their plexiform neurofibromas. So all great news, but things to consider as you're talking to your patients is, when will this happen? Does it happen immediately? Does it take several months of treatment before you see this? And the answer is that it'll probably take several months before you see some shrinkage. However, we'll talk a little bit about the pain, for example, and the quality of life, which can improve earlier. So you don't have to wait for a full 6 months to a year before you see shrinkage, before you start seeing quality of life and pain improvement in these patients. And so like with the children in this analog NRS 11 score of pain, the majority of patients who had pain at the start had a decrease of those scores, an improvement of their pain, and the quality of life also improved as they started treatment with mirdametinib as part of the ReNeu study. Again, a little bit redundant from the pediatric slide regarding adverse events, but almost everyone had a form of adverse event. Fortunately, most of those adverse events were low grade and adverse events that were either manageable or tolerable. But again, rash, very, very common. And one thing that we see often is that acneiform rash that Dr. Bornhorst was talking about that can affect really the face and any other part of the body, but we see it very much in the face, chest, back, sometimes the arms as well. And even though the FDA package doesn't say that you need to start treatment preemptively, sometimes many centers do that by starting a prophylactic therapy to improve the rash or decrease the possibility of having a severe one. Diarrhea, nausea, vomiting, and abdominal pain are common. One of the most common side effects that is asymptomatic in most cases, and again, same as with kids, is the elevation of CK or CPK. And I completely agree with Dr. Bornhorst. Sometimes we see scary looking elevations of CK as long as the kidneys are staying okay and the patient is asymptomatic. Otherwise, we tend not to do dose modifications or hold the medication because of CK elevations. But all of these other things that you see on this list are things that we have seen to greater or lesser extent. Now, that was ReNeu, mirdametinib. Switching to selumetinib, the other MEK inhibitor that is approved. By the way, in terms of FDA approval, and Dr. Bornhorst, I think, and maybe Dr. Herby as well, have mentioned already that there's 2 FDA-approved MEK inhibitors, mirdametinib and selumetinib. Unfortunately, right now, the only one that is approved for adults is mirdametinib, and that's great. As of February of this year, we have a MEK inhibitor that is already approved, so we usually tend to go that way because it's easier with insurance. But the side effect profile, as Dr. Bornhorst was saying, is pretty similar between both of these MEK inhibitors. Now, the COMET study was just published earlier this year, and even though I'm going to talk about the COMET study, you already heard from Dr. Bornhorst a little bit about the phase 2 adult study with selumetinib that was that happened before COMET. But in COMET, again, patients were people with NF1 adults that were randomized to either received selumetinib at the standard dose of 25 milligrams per meter squared twice daily, and selumetinib is administered on a daily basis as opposed to 3 weeks on, 1 week off, or to a placebo twice daily. And then at 12 months or 12 cycles into treatment, all the patients in the placebo arm were switched to the treatment arm as well. And a lot of the comparisons that you'll hear about today are between the first 12 cycles of both arms, where somewhere on the placebo and somewhere on the treatment side. You see that the median age was 29 years of age, about 50-50 ratio of male to female patients, and the location of the tumors was, again, as before, in different parts of the body. They were not specifically looking at one particular body part. You can see in this swimmer plots here that there were a good number of confirmed responses. About 20% of them responded, and other patients that had improvement of their size of their plexiform neurofibromas, as you can see again in the waterfall plot, but only 20% achieving that 20% volumetric reduction. Most of them with some degree of reduction, a few of them, maybe one, that achieved stable disease if the tumor was growing. One important thing to consider is that we don't know from the COMET study, because it wasn't captured, how many patients entered this study with progressive tumors versus how many entered with stable tumors. So an important consideration as you're talking to your patients. Like with mirdametinib, in selumetinib you have a lot of side effects. 100% were reported to have side effects in the COMET study, but most of them, again, benign, or I should say low-grade side effects that were typically manageable, with the same ones on the list: diarrhea, nausea, vomiting, that acneiform rash, and increased CK levels. Like with mirdametinib, patients with selumetinib also achieved improvement of their pain and improvement in their quality of life. However, one thing that was slightly disappointing was that this was not statistically significant when compared to the placebo arm. So this is just a comparison a little bit of both selumetinib and mirdametinib, both available, both FDA approved. Mirdametinib for adults and children, selumetinib only for children. As of earlier this week, selumetinib in the sprinkle formulation was approved by the FDA. Mirdametinib comes with a dispersible tablet that you put in water, it dissolves, so you can just drink the water if you're a child that cannot swallow. Now, continuous therapy is recommended for both, typically until disease progression or intolerable side effects. We were discussing earlier how we treat our patients, how long we treat our patients for. That's an ongoing question for which I don't think anyone has the correct answer, but more to come hopefully in the next few years to learn more about that. Now, it is important, and Dr. Bornhorst already mentioned this, that these therapies that we're talking about today are focused exclusively on benign plexiform neurofibromas, that none of this truly applies to that cancerous transformation to malignant peripheral nerve sheath tumor when that happens. And an important thing that I often get asked in clinic about is which one is better? Which one should I choose? Should I go for selumetinib? Should I go for mirdametinib now that they're approved, especially in the pediatric population? Well, we don't know. There are no head-to-head comparison studies looking specifically at the question of which one is superior to the other, and I doubt that there will unfortunately ever be a head-to-head comparison study that will definitively answer that question. There's no data also about switching from one MEK inhibitor to the other that has been published, but there's anecdotal evidence that maybe if you're not tolerating selumetinib well, you might do better with mirdametinib, or vice versa. Why, we don't know, but some providers have reported that anecdotally. And then in terms of long-term, Dr. Herbie is going to talk to us about that a little bit.
So we'll come back to this patient case again. So Mary G. Mary receives mirdametinib, and her facial tumor shrinks to approximately half its original size, and the pain improves substantially. However, she develops a grade 4 CPK increase. So what's the next best step? Assess for symptoms. If asymptomatic, continue therapy. Switch to selumetinib, withhold until less than grade 1 and resume at a lower dose, I will say, or the same dose, and then or permanently discontinue treatment. It's a good split. Miriam and I were talking just a minute ago about which would you do versus which would I do. So I think assess for symptoms, and if asymptomatic, continue therapy is what you would probably do. I think technically the label is, if it's grade 4, that withhold until less than grade 1 and then resume at the same dose, not necessarily a lower dose. I did have a patient recently who was totally asymptomatic, but the CPK was 17,000. I hadn't seen one quite that high before.
I can't remember what is the definition of grade 4. Maybe it is symptomatic, but does it include symptoms?
No, it doesn't include symptoms.
It's
just a value number.
Just a value number. And again, when most of the patients are asymptomatic, I don't necessarily think to resume at a lower dose. But
on the peds side, we don't even check it a lot of the times now anymore, just because we don't stop therapy for an elevated CPK. And so I think it's, I probably have patients out there with a 17,000 CPK and I just don't know.
I still check it.
Yeah. Follow the label.
Follow the label. Do what that says.
So just kind of going through the monitoring that we should do on these medications. So again, in terms of exam, kind of you're doing a good physical exam every time. and asking patients about symptoms like their GI symptoms. Vision is monitored. A good skin exam, they're going to tell you if they have the rash. And then nail exam, looking for paronychia, which I think much more in peds than on the adult side. I've actually never seen anybody have paronychia on the adult side. Ophthalmologic exam, so you get an eye exam at baseline, and then every 6 to 12 months. I typically do it every 12 months in the adult patients. Echocardiogram with ejection fraction, again at baseline, and then guidelines every 3 to 6 months. I will typically do every 6 months. I just do it when I scan the patients, which I do about every 6 months when off trial. EKG at baseline, and then just as clinically indicated, pregnancy status, baseline, and then per institutional standards. Laboratory exam. So again, baseline, I will typically do labs every 3 months, and we're looking at a CK, metabolic panel, LFTs, CBC. So just kind of the general things that, we think about in terms of the safety. The rash is something that I think you see in almost 100% of patients. On the adult side, it tends to be more of the acne rash, I guess, in adolescents and adults. I think that can be so severe that in my practice, I will pre-medicate patients to try to avoid that. So at the time that patients are starting a MEK inhibitor, I will start doxycycline at 50 milligrams a day, so not like an antibiotic dose, but just an anti-inflammatory dose. I also give them clindamycin lotion, and that was something that I started doing working with our dermatology team. Usually I can just have them on that for about the first 3 months, and then I'm able to peel that away, and I think the body becomes accustomed to the MEK inhibitor, and the rash seems to not be such a problem after that. In terms of the kid side, I think paronychia is, more common there and a problem that you guys have to monitor for. Weight gain, I'm starting to see more in the adult patients and the patients that have been on for a long period of time. And we'll come back to that in one of the questions so we can sort of get input from all of us on that. And then GI problems, I think in the adults, more diarrhea. I think in the kids, it's often more nausea that can happen. So, just in summary, patients with NF1 are at risk for tumor and non-tumor manifestations necessitating care from a multidisciplinary team. Plexiforms are one of the most common tumor manifestations in patients with NF1, and there is a significant risk of malignant transformation. These can be managed surgically. I think very exciting now we have MEK inhibitors as approved therapy, for these patients, and then clinical trials are an option as well. And there's many areas of ongoing research to improve therapy for patients with NF1-PN. We sort of alluded to some of these in terms of how long should a patient be on therapy, and things like, is adjuvant therapy something that we should be doing in the patients that get debulkings. The goal of transition of care is to maintain optimal health care, which can only be achieved when every person at every age receives medically and developmentally appropriate care. Bringing up some of the clinical trials, as we mentioned, that are on the horizon or already recruiting patients. So this HELIX study in adult patients with NF1 and inoperable plexiform neurofibromas is recruiting. This trial is being run through the NF Clinical Trials Consortium. The INSPIRE, which is a phase 2 open label study of HELIX, again through the NF Clinical Trials Consortium. And then there's this selumetinib for the prevention of plexiform neurofibromas, which will be opening at the NCI, and this is not yet recruiting, but this will be starting patients, very young children, before they're symptomatic, and seeing if we can prevent problems from plexiform neurofibromas. So SMART goals, putting the information into action. So refer patients to NF1 centers. NF1 is a complex disease. You really need support from many specialists. It's important to have a robust multidisciplinary team for the care of NF1 patients. And it's important to implement strategies to improve transitions from the pediatric to the adult setting. So we have a lot of questions that have come through virtual. So we'll go through these and then take any questions that the audience has as well. So let's let's see, the first one was, what's the recommended frequency and modality of neuroimaging for monitoring optic pathway gliomas and paraspinal plexiform neurofibromas in patients with NF1?
Yeah, so that's because optic pathway tumors are generally a pediatric issue. Once you become an adult, that's not something that you probably ever even think about. And even on the pediatric side, if you don't see it until, like 8 to 10 years of age, you generally don't really think about it anymore. So optic pathway tumors are most commonly a problem and diagnosed before, I would say, around 10 years of age. There's a lot of debate on how to look for optic pathway tumors. I know there's some centers that will just do screening MRIs around 2 years of age, and kind of they use that as their guide. There's a lot of centers that use primarily ophthalmologic evaluations, because you can actually pick up, especially now with OCT, you can pick up changes in that nerve fiber layer. You can also see obviously paleness of the nerve. Sometimes you can even see sort of like I don't know, like my ophthalmologist calls it edema or swelling. Like you can see like slight mild changes of that nerve that can kind of tell you that there's a tumor. And so, as long as the patient is having consistent eye exams, so I would say definitely at least once a year, but some places will even do it every 6 months. You don't necessarily have to do imaging. And if there's ever anything on that eye exam that's concerning, making sure that you're getting imaging at that time. So that's sort of what the general guidance is right now for optic pathway tumors. Now, of course, there's a lot of studies that are being done to look at surveillance versus not versus others. This guidance might change in another 5-10 years, but right now that's the general consensus, is making sure that they're getting that eye exam no matter what, and then MRI if there's concerns.
And they asked about paraspinal plexiform neurofibromas.
Oh, and the paraspinal, yeah. Go ahead.
No, I was going to say for plexiforms in general, I think our peds group will usually image those kiddos once a year or as clinically indicated.
Yeah. And I would say in terms of finding them, that's also under debate because there isn't really anything telling us, you should do a screening whole body MRI at this age. I think a lot of us are starting to do screening whole body MRIs before patients transition from kind of their pediatric to the adult care. But in terms of like younger age, I don't necessarily do imaging of the spine unless there's something I'm concerned about, like scoliosis. We know that scoliosis about 40% of the time is associated with a plexiform. So I'm going to get imaging at that time. And then any concerning findings on the exam is going to kind of trigger me doing those MRIs as well. But once you find something, then every 1 to 2 years, depending on how it looks, depending on where it is, it would be how I would follow it.
So everyone gets an eye exam no matter what.
Correct.
And everyone has to have neurologic examinations
Correct.
Periodically, no matter what.
Yep.
Whether you get MRIs of the spine or the eyes and orbits, depends on institution. There's no guideline that says you must do this or that. I am with Miriam. In our institution, we don't automatically get MRIs in kids who were newly diagnosed with NF unless there are clinical manifestations that worry us. Now, if parents are worried, there might be a discussion about the risks and benefits of getting the MRI of the brain or the spine. It's just more of a conversation.
Yep. And I'll also throw out there on that list of clinical trials that are ongoing, the NF114, the last one on that list, the prevention study. That is going to be a really good study, I think, for us in a couple reasons. First of all, it's going to help us understand if MEK inhibitors can prevent sort of the progression of these tumors and therefore prevent morbidity. Because right now we mostly are trying to treat morbidity, not necessarily prevent it. So that'll be one good outcome of that. But the second one is that we're taking 250 patients with NF1 who do not have known plexiform neurofibromas, and we're giving them whole body MRI imaging, plus the thought is that we might also look at their brain. And so that's going to be a great way for us to say kids between 0 and 8 years, or I think it's 1 and 8 years of age who are eligible for this study, how many of them have tumors, what are we identifying, how many of them actually need treatment, and is this kind of screening sort of approach the best way to do this or not. So I really do think in 5 to 10 years we'll have better guidance on how to do this.
So the next question was, will all patients who present and meet criteria always develop tumors? And the answer is no, they will not. So we said about half of patients with NF1 are going to have plexiform neurofibromas. And then a subset of those patients, may progress to malignant peripheral nerve sheath tumors. But this kind of goes along with the very variable disease presentation that different patients can have.
Yeah. However, I would just add that about 95 to 98% of people will develop cutaneous neurofibromas, which are not malignant tumors and really have no risk of malignant transformation or very, very little risk of malignant transformation. But it is a type of tumor that happens in most people with NF and can be quite bothersome.
Next question was, how should neurologists balance MRI surveillance versus symptom-driven evaluation in asymptomatic pediatric NF1 patients? I think we kind of touched on this. We don't necessarily image asymptomatic patients.
Correct. Unless there's something that the patient has that's strongly associated with a tumor. Like I said, scoliosis, for example, or you notice an extremely large cafe au lait spot that has hair on it, there's probably something underneath it. Things like that would potentially trigger even if they don't have symptoms. But yes, otherwise I think we covered everything.
All right. What criteria should guide switching between selumetinib and mirdametinib in the event of toxicity or suboptimal response? I don't think there's any hard and fast criteria. I will say anecdotally, I have seen a patient respond to a different MEK inhibitor after being on a prior MEK inhibitor. So if something stopped working, then I would, consider trying a different MEK inhibitor. If toxicity was the reason for coming off therapy, in my experience, I generally think people have the same toxicity on either medication,
Yeah, I mean, one thing I would add here is if you're thinking about toxicity with one of these medications, the other thing you could consider is cabozantinib, which has also, again, Dr. Bornhorst had that MAP kinase pathway. And beyond just MEK inhibitor, the only other medication that has been shown to be beneficial for plexiform neurofibromas that are benign would be cabozantinib, or enroll them in a clinical study, such as the HELIX study, which is currently open, which is not a MEK inhibitor. But as I've mentioned before, and Dr. Herby just mentioned as well, if a patient didn't tolerate selumetinib, maybe they will tolerate mirdametinib better, or trametinib, or one of the other MEK inhibitors. So it's not out of the realm of possibilities to try another one.
Yeah, and I would say too that I've actually had more than one instance where a patient had what seemed like a true allergy to one MEK inhibitor, and then I put them on another one and they didn't have the same response. I don't think it was the MEK part of it. I think it was whatever it's compounded with that they had an allergy to. But that's another case where you might want to consider switching. Like, those patients where they start taking it within a week, they have fevers and extreme diarrhea and rash from head to toe, and they're losing weight and they just look horrible. Like, take them off and you can try another one and see if maybe it helps. And I've been successful with that a couple times.
And we'll only point out that cabozantinib is not FDA approved for plexiform neurofibromas.
Yes.
But I use it a lot in the oncology setting, and I think cabo in general is harder to tolerate than a MEK inhibitor.
Yeah.
But every patient is different.
Yeah.
Next question. How can neurologists best monitor and mitigate cardiac and ocular toxicities during long-term MEK inhibitor therapy? So I have not seen any ocular toxicity in any patients that I've treated with a MEK inhibitor. I still do, eye exams every year, and at baseline, certainly, based on all of the trials for all MEK inhibitors, it certainly is a risk. But I think, just making sure the patient sees an ophthalmologist every year is important. In terms of cardiac, monitoring, we do echocardiograms, and I do them every 6 months. If I see any drop in the ejection fraction, then I will refer patients to one of our cardio-oncologists. So there are cardiologists that work very closely with patients who are on different oncologic agents to make sure that you're maintaining heart function.
We're currently studying, there seems to be a greater incidence of dry eye syndrome in people with a MEK inhibitor. That's something that is currently being investigated. So it might be that, yes, the bad side effects like RPED or retinal vein occlusion, that's not something that we can prevent, but treating dry eye syndrome with just artificial tears might be a simple solution to one of the more common blurry eye side effects.
How do you manage weight gain on a MEK inhibitor? I'm seeing this more in my practice, and it can be significant. This online person said so far just with selumetinib. I've seen it with both. Honestly, the patients that I have now who have been on, adult patients who have been on MEK inhibitors for 5, 6, 7 years are gaining weight over time. I have been referring them to our weight management team so they can kind of go through meet with the nutrition, really go through dietary things and exercise programs. But I think we don't have a perfect answer for this right now.
Yeah, I would agree. I mean, I'm actually studying this right now. So if you ever want to hear why patients gain weight on MEK inhibitors, I have a great talk on that. But the short answer is I'm hoping to have some sort of a solution to this soon, but it's not available yet.
What malignancies are associated with NF1?
Multiple,
Yeah.
unfortunately, and multiple and at different ages. So anything from JMML, leukemia that happens in the pediatric population almost exclusively, ranging to breast cancer, which is diagnosed in women as young as in their 20s, but the higher risk is between 30 and 50. MPNST, which happens at around the same age for its highest risk, although we've certainly diagnosed young kids with MPNST. There might be very well increased risk of melanoma, squamous cell carcinoma, rhabdomyosarcoma was mentioned before. So there are unfortunately a good number of malignancies, including central nervous system tumors, both low grades that we tend to see more in children, but also high grade tumors, including anaplastic astrocytoma and glioblastoma in adults, which is unfortunately universally has a very, very poor prognosis.
I feel like you hit everything other than gastrointestinal stromal tumors. You see those too. Yeah.
And neuroblastoma in kids.
What is the variability in penetrance and presentation in families with NF1?
Well, it's an autosomal dominant condition, so 50% chance with each pregnancy. Penetrance is 100%, so there is no variability in penetrance. So if you have an NF1 pathogenic variant, the patient will develop some symptoms. Where there is variability is in the expression of NF. So in the case of our patient advocate, she was mentioning that dad was not diagnosed until he was 36, I believe she said, and that probably was because he had very, very minimal manifestations, but their son has a large tumor in the neck and their daughter is doing a little bit better, but has some other manifestations. So variability in expression, yes, but penetrance is 100% for NF1. That is different for the other schwannomatosis, especially LCTR1 and SMARCB1, but that's not the topic of this conversation.
Are there any notable interactions with MEK inhibitors and other medications, or any absolute contraindications to starting therapy?
I think the label says no contraindications. However, I would say pregnancy is probably a pretty definitive contraindication. There are a few interactions that you should consider evaluating, but usually there are no interactions that will preclude you starting a MEK inhibitor.
Anti-epileptics, I feel like, are the ones where those drugs interact with everything.
So you have to be careful. The ones that are enzyme-inducing, so carbamazepine, things like that, dilanthane, phenytoin, yes. But the newer anti-epileptics that we use, levetiracetam, brivaracetam, lacosamide, zonisamide, those are pretty good. And so that's a great question for this meeting, where we have a bunch of neurologists treating patients with an F1 and that are about to start either a MEK inhibitor or chemotherapy. So I think particularly relevant for this meeting is try to start a non-enzyme inducing AED. So the ones I mentioned are perfect. Stay away from the carbamazepines, phenytoins, things like that.
And then they do recommend caution with SSRIs. So just be careful if you start a patient on a MEK inhibitor with this SSRI. And every patient I've had with a GI bleed, like a true GI bleed on a MEK inhibitor, was on an SSRI, and so that caution that it might increase your risk for a bleed is real. So just be very careful. That's all I'm going to say. Not that it's contraindicated. You just have to be cautious and watch them more closely.
There's a question about a 17-year-old on selumetinib wanting to switch as he transitions to adult mirdametinib. How do you switch? Any AE concerns during the switch? And if a patient's doing well, I don't necessarily switch. There might be a reason that someone wants to switch. Selumetinib is every day continuous dosing, whereas mirdametinib has the built-in week off. So a patient may want to have a week off of therapy. So, if you were transitioning.
Yeah, so when I transition, basically what I'll do is I'll give them like 5 to 6 half-lives. And so the nice thing about selumetinib is that the half-life is really short. So it's basically like 3 days off, and then you can go right back on the drug again. And that's worked really well. I try not to keep patients off too long. I don't know if any of you have treated with MEK inhibitors, but if you just stop at cold turkey, the poor patients will actually have rebound side effects. And so their side effects are worse when they come off than sometimes when they go on. And so I try to make that transition period as short as possible. So I tend to look at half-life and do it that way, and I've had really good success with that. I don't know if you guys have done anything differently.
No, I agree. And I would add a different question here that I get asked often, which is, if we decide to stop for whatever reason, will the tumor grow, and is there a rebound growth? So Miriam, I think what you're saying is rebound symptoms, specifically pain.
Right.
But do we think that stopping a MEK inhibitor makes the tumors increase in size exponentially? Or what are your thoughts on that?
In kids, you can absolutely see that, where if you stop it too cold turkey or too quickly, like I can see tumors completely balloon up just off of drug for a very, very short period of time. So again, I'm very, very cautious if I'm stopping a drug. I wean, and you're going to start hearing that a lot more from people. Like if you're going to stop the drug, wean off of it, because you're less likely to see that sort of immediate regrowth. But yeah, I mean, I've had kids who, again, tumors have like double, tripled in size just being off of drug for a very short period of time. So it's something that I think in adults it's not so much maybe, but kids, be careful in kids.
I would say still in 20s too, as I have 20-year-olds, like I think they still can get that rebound pretty significantly, but adults that I've had like late 30s, 40s, 50s, where I've stopped after a couple of years, have not had rebound in pain or tumor growth.
Yeah. Kids are a little bit different.
Yeah. I know we don't have very much time left. There's still some questions online here. I'll try to go to ones that we really didn't address. So do MEK inhibitors affect cutaneous neurofibroma development?
That's a great question. The answer is probably yes. However, there's no data to fully support this. There was a study done at the NIH where they recruited 10 patients for treatment with selumetinib for cutaneous neurofibromas. It was just a very difficult study to recruit for. It happened during the height of the pandemic, so more data to come. At my institution, we're currently running a study using mirdametinib, where we prescribe it for cutaneous neurofibromas, and I can't speak too much about the results because we are still very, very early in the phases of looking at those results, but it probably does something to help.
Someone asked a question about how often we see patients have anxiety. We often see patients have anxiety when they transition to adult care. How do you manage that? At our institution, we have a bi-monthly meeting with the peds side and the adult side where we're going over all those patients ages 14 to 18 years. And we kind of flag the patients who we know are going to have anxiety with transitioning. And we will alternate visits sometimes for a couple years to sort of make that transition a little slower. So there's kind of having both of us involved in their care for some period of time. I don't know if anybody else has anything to offer to that one. All right.
Are there any questions in the room? Okay, we have a bunch more to go through here. I don't know how much time we have left.
I think we're at time. Yeah. But, this one was.
But there's a couple of questions about neurologists and how can they be involved. And I think I can answer that if that's okay.
Yeah, please.
I'm a neurologist, so I think you can absolutely be involved in the care of people with NF1. I think one of the main takeaway points from this conversation, if you don't feel comfortable treating the plexiform neurofibromas, at very minimum, I think you can talk to them about the diagnosis, make that diagnosis, make the appropriate referrals. I think that's for sure one of the easy things that any neurologist should be able to do. We've talked about neuropathic pain as part of the symptoms associated with plexiform neurofibroma. Neuropathic pain from a plexiform tumor is treated the same way as neuropathic pain from the peripheral neuropathy from diabetes. So there are a lot of things that a neurologist can do to advocate and treat their patients, especially in areas where there's no NF centers of excellence.
Yeah.
There's a
How easily accessible are the MEK inhibitors for patients, especially in those patients that have to maybe travel a long way to get to a competency center or have lack of insurance? Are there any programs or supports in place to help them get access to these meds?
Yeah. Yep. So both of the medications have patient assistance programs that are amazing. And so I would say definitely if you have a patient who's having trouble in terms of the financial aspect, look into that. It's a little different if you have Medicaid versus non-Medicaid insurance. So that's something you'll have to keep in mind. And then the other thing to kind of keep in mind is that right now for both of these medications, there's sort of like a centralized pharmacy that distributes. I think it'll change a little bit for the mirdametinib, but selumetinib is still only using kind of a centralized pharmacy, Onco 360. And so the medication gets mailed to you basically. So you don't have to go to your pharmacy. You don't have to worry about it not being available. It's mailed and they are so good. Like they just really, they're on top of it. The pharmacy will call you when you need a refill. I mean, they're really amazing, to work with. And so families never have trouble with that aspect of it. And like I said, the patient assistance programs have been really, really great for our families too. And it's really easy to make that referral.
And again, just to add one last thing, you don't have to be in an NF center to receive treatment for a Plexiform. Mm-hmm. I often see patients that come to us for a second opinion, but they're from out of state. And often they'll go back to their local oncologist, typically local oncologist, and I will communicate with their local oncologist and say, this is what I would do here. Can you start this plan of treatment? And that is usually very doable as well.
Yeah. And I see that a lot in Missouri. We have a pretty wide catchment area from St. Louis. And so I may see a patient once a year and be giving recommendations to their local oncologist for treatment.
Yeah. The only thing I just want to add to is keep in mind that insurance companies follow that indication, and so do the patient assistance programs very, very closely. So as soon as your patient hits 18, that anything related to selumetinib is no longer available, at least in terms of the patient assistance programs. And so just keep that in mind. Like follow the indication when you're trying to use these programs.
And another reason for switching in the adult setting. If they relied on the patient assistance program, they would probably have to switch.
They would have to switch. Yep. And I've had to do that. And I think all of us have had to do that. Yeah.
Thank you, Miriam and Carlos, for doing this together. This was fun. And thank you, everybody, for coming out today.